Hi everyone, this is Kathleen Pelias and I'm here to present my week 4 case. Her name is Mrs. R. She's 56 years old, uh, African American female. Her chief complaint is I am having shortness of breath and chest pain for the past 7 days. Her HPI, she presented to the clinic alone with complaints of shortness of breath and chest pain. And she is reporting that these symptoms were progressively worsening since it started 7 days ago. In addition, she had been experiencing fatigue and difficulty in performing her daily activities at home. There's no cough, no fever, no chills, or night sweats. However, the shortness of breath occurs on both at rest and with mild exertion. And she said that it is often accompanied by a feeling of tightness in her chest. The chest pain was described as a constant dull ache and was present throughout the day. Her medical history, she had an unremarkable past medical history except for COPD. She has a 1 pack a day tobacco smoking until age 45 from age 13. She has not used her inhaler for over 3 years now. She does not use her oxygen because she's embarrassed to use it in public. Her last visit with her pulmonologist was 3 years ago as well. She and her family does not have any known cardiovascular or other pulmonary conditions except for her mom, who has asthma, which might be relevant for her current presentation. She mentions that having occasional headache, but otherwise she feels well, and she also denied any significant medical events, hospitalizations, or surgeries in the past. She reports no history of bleeding disorders, anemia, or an immunocompromised status. Exam findings. She appears anxious and distressed. Her vital signs are normal. Temperature 98.4. Heart rate is 97. Respiratory rate is 24. Blood pressure is a little elevated, 156/94. Oxygen sat is 90%. Cardiovascular has a regular heart rhythm with no murmurs, rubs, or gallops. Chest, mild intercostal retractions and decreased chest expansions, especially on the left side. Lungs, auscultation of the lung reveals decreased breath sounds in the lower left side or lower lobe with occasional wheezing. Cardiac examination also showed regular rhythm. There were no peripheral edema or cyanosis noted. Abdominal examination, it's soft and non-tender abdomen with no palpable masses or hepatosplenomegaly. She has normal bowel sounds in all 4 quadrants. No signs of focal deficits, normal strength, coordination, sensation, and reflexes were observed. Her mental status appeared clear with good orientation, intact short-term memory, and long-term memory, and normal mood and affect. My 3 differential diagnoses will be COPD, pneumonia, asthma. Correction, acute exacerbation of COPD. Potential differential diagnosis was COPD was the first. According to Augusti et al. 2020, COPD is a chronic condition that typically results from a long-term exposure to lung irritants, such as cigarette smoke, chemical fumes, and air pollution. Individuals suffering from COPD may experience a gradual worsening of their symptoms, but acute exacerbations can occur and lead to severe breathing difficulties. Respiratory infections, changes in weather, or exposure to irritants may cause acute exacerbations, according to Augusti et al. 2020. She reported symptoms of shortness of breath and chest pain that are consistent with COPD. Pneumonia is my next differential diagnosis. According to Ticona et al. 2021, established that pneumonia can present with symptoms such as fever, cough, chest pain, and difficulty of breathing. Her shortness of breath and chest pain could be caused by pneumonia, which may be more severe given her age and potential weakened immune system. However, I ruled it out because there were no fever or cough. The third differential diagnosis is history of asthma, family history of asthma. Sorry, my third differential diagnosis is asthma. This is because of her family history. Her mother has an asthma, might be an asthma exacerbation. It is a chronic respiratory condition, results in inflammation of airways, leading to narrowed airways and difficulty of breathing. Ramsahai et al. 2019 contended that asthma exacerbations can be triggered by numerous factors, including allergens, irritants, respiratory infections, and exercise. An asthma exacerbation can also result in severe shortness of breath and chest pain. All right. My final diagnosis will be acute exacerbation of COPD. To confirm it, we did a spirometry according to GOLD, Global Initiative for Chronic Obstructive Lung Disease guidelines, recommended using the ratio of FEV1 and to FVC to categorize the severity of COPD. This is according to Patel et al. 2019. If the ratio is less than 0.70, it confirms the diagnosis of COPD, and hers was 0.64. We ordered chest x-ray too, and it showed that there's a lower left lobe consolidation. This is also suggestive of COPD. We gave her doxycycline twice a day, 100 milligrams for 5 days. According to GOLD guidelines, antibiotics should be given to patients with exacerbations of COPD who have increased sputum purulence, cough, and shortness of breath, according to Patel et al. 2019. We also ordered arterial blood gas to support the final diagnosis. Blood tests including CBC, CRP, and procalcitonin were ordered to assist in differential diagnosis. We also ordered O2 therapy, 2 liters per minute nasal cannula to maintain her oxygen level above 90%. Standard guidelines recommended a target saturation range of 88 to 92% in patients with COPD to avoid hypercapnia. This is according to Patel et al. 2019. The flow rate of oxygen was titrated based on the patient's oxygen saturation level. We also advised her to take salbutamol 5 milligrams, salbutamol and ipratropium bromide 2.5 mg and 0.5 mg every 6-8 hours as needed. Paracetamol, Tylenol every 6 hours for mild and moderate pain. And for severe pain, we also ordered oxycodone 10 milligrams every 6 hours as needed. We also advised her to go back and see her pulmonologist to better manage her COPD acute exacerbation. Patient education, strict adherence to medication. and also avoid any specific triggers for her COPD. That's it. Thank you so much. Thank you for listening.